Yes, welcome to the afternoon session. We're getting ready to start. We're going to start off with diabetic retinopathy, and I'd like to introduce our moderator, Lisa Olmos.
Thanks, everyone, for coming back. We have a great lineup of talks for diabetic retinopathy that are promising to be both very practical and thought-provoking. Our first talk will take us beyond Protocol S for real-world treatment of proliferative diabetic retinopathy by Dr. Adrienne Scott.
Hi, thank you very much, Lisa, and thank you to the program organizers for the opportunity to give this presentation. I want to understand how Protocol S has been applied to the community, and like to just make everyone aware this is the work of Jay Maturi, is one of our Hopkins medical students. These are my disclosures. So we know we want to avoid anyone going on to the possibly vision-threatening PDR, and essentially everyone may start out with a normal fundus. And we know that Protocol S taught us that anti-VEGF therapy could be non-inferior to the gold standard, which is PRP, shown to decrease vision loss from PDR. But how many people in the community or real world or in our community are really adhering to this protocol? So Protocol S, we have long-term results, and it's fantastic. We found that anti-VEGF performed to be non-inferior to PRP for patients. And essentially, they may even have a slight vision gain compared to PRP, but essentially, the results were non-inferior. So our question is, are patients able to complete regular visits for anti-VEGF injections for proliferative diabetic retinopathy outside of the clinical trial setting? We wanted to evaluate community treatment patterns for patients with PDR to characterize the extent and loss to follow-up in patients treated with anti-VEGF agents for PDR, and to measure what's the impact, what's the effect of noncompliance or adherence with treatment with anti-VEGF therapy on the patients that are lost to follow-up or non-adherent. So we looked at the Vestrum Health Retina database, and this was a retrospective study of a big data insurance analysis, and we included any patients with proliferative diabetic retinopathy in the database between the years 2016 and 21 who received at least one anti-VEGF injection, could not have received any prior anti-VEGF treatment or panretinal photocoagulation or vitrectomy. So the cohort included approximately 26,600 eyes. As you can see, we divided it up into PDR with and without DME. The patients with DME, unsurprisingly, tended to be got a little bit more of the injections than the patients without DME and PDR. You can see that treatment essentially waned over time. But you can see the number of injections from year 1 was about 1 or 3 injections, 4 or 7 maybe in year 2, and waned as the time went on. So Protocol S we defined concordance with Protocol S by the DRCR-net, as we were very liberal with our definitions for how much concordance was allowed. So 4 anti-VEGF injections within 14 weeks of their baseline injection for PDR. So who's really doing this outside of the clinical trial? And you can see this graph that shows not that many folks are concordant with Protocol S, and that could be patient factors, it could be clinician factors. You could decide to extrapolate and use Biosimilars as opposed to ranibizumab, and all kinds of things thrown in. But this is, you can see the cohort that is not compliant with Protocol S. Who are the patients that are less likely to be concordant with Protocol S treatment with anti-VEGF or PDR? These are patients who are smokers, who are on Medicaid or Medicare. These are older patients, interestingly enough. And more concordant patients tended to have DME present, be from the West, and maybe a little on the younger cohort. And again, we define flexible adherence, okay. So what if you weren't strictly about Protocol S? What if we were kind of flexible with that? Flexible adherence was defined as 4 anti-VEGF injections within 26 weeks of the baseline injection, and this data was able to be mined from insurance data and claims. So we can see the loss of follow-up here. About 42% of patients with DME and 48% of patients without DME had a 6-month period of a loss to follow-up in the community setting. So these patients, for whatever reason, they don't come back as regularly as they were assigned to in the clinical trial. So we said, okay, what about after 6 months? And you can see the difference gets even more stark. Increased loss to follow-up occurred in patients that had Medicaid, active smokers and former smokers, older patients 70 to 79 years old and over 80 years old. And those are the patients that were less concordant over time with Protocol S results. More concordance obviously was seen with patients with DME and in the rural setting. Now, what about loss to follow-up again? The smokers, the older patient cohort, and male sex tended to be lost to follow-up a little bit more over time if patients did not have concordance to Protocol S. Complications. So we can see a slightly increased rate of complications in people who are not concordant. So these complications were divided into things we face often in our clinics: retinal detachment, vitrectomy, neovascular glaucoma. And the key takeaways from our study is that only about 12% of patients with PDR received care concordant with Protocol S by the DRC-NAT standards. Over 40% of patients were lost to follow-up within a year, and there is poor adherence to the regimented strategy of anti-VEGF care. Maybe in the real world, we know anti-VEGF therapy essentially is shown to be non-inferior, but maybe in the community, the guidelines aren't applied as stringently, and maybe the treatment may not be as effective. So we need to consider a patient's personal circumstances that influence likelihood of follow-up when determining the optimal therapy of PDR. Thank you very much for your attention, and I'd like to highlight Jay Maturi, who's one of our fantastic, yes, the name should be familiar, one of our fantastic Hopkins med students, and this is his brainchild and his work that we're presenting today. Thank you for the opportunity.
Thank you, Adrienne. Next, we'll hear from Dr. Neil Bressler on management of diabetic macular edema in an era of Faricimab, Aflibercept 8 milligrams, and biosimilars.
Thank you, Dr. Olmos. Thank you, Dr. Blody and Bakri, for a wonderful subspecialty day and inviting me to give this talk. These are my Academy disclosures and my other disclosures on this slide. And back in 1986, the New York Times wasn't even electronic, but on October 19, they were discussing the Boston Red Sox playing the New York Mets for the World Series. And there was a lot going on at the Academy because it was no longer just observation, but now focal grid laser joined our toolbox of treating diabetic macular edema, because instead of 30% losing 3 or more lines of vision by 3 years, it was only 15%. But it wasn't until 24 years later that any new story occurred. The New York Times now is electronic, and the Yankees are participating in the playoffs. It's not even the World Series during October 19. And there are 2 more items to consider in our toolbox. And that's because Protocol I from the DRCR network published in the Ophthalmology Journal in 2010 that laser on average improved vision. We knew that, but what we didn't know was the substantial increase that occurred using ranibizumab, either deferring laser for at least 6 months and maybe never if the edema had stabilized. And with prompt laser, it was no better if you combined it at the start, but certainly it was superior to laser. Corticosteroids with laser were no better than laser alone by the time we got to 2 years. 5 years later, 2015. Now on October 19, the New York Times tells us the Blue Jays are playing the Texas Rangers now for a divisional playoff. But we also have 2 new items to consider in our toolbox for evidence. This is repackaged compounded bevacizumab and Aflibercept at 2 milligrams. Protocol T was published then in 2015 in the New England Journal of Medicine, where it was learned that no matter which agent you used, the visual acuity on average was the same if the starting visual acuity was 20/32 to 20/40, but when the starting visual acuity was 20/50 or worse, on average, Aflibercept had superior visual acuity outcomes to either ranibizumab or bevacizumab. Prior to this, you would see marketing and advertising to tell you why one was better than the other at any vision. But now we can fall back on the scientific evidence and say, well, no difference at 20/32 to 20/40, but a substantial difference when we talk about eyes walking in at 20/50 or worse. 9 years later, here we are, October 19, the New York Times doesn't even have a sports department anymore. They bought The Athletic to get rid of their sports department and used The Athletic to report that last night the New York Mets are hanging on against the Los Angeles Dodgers in the playoffs. And we're thinking, is there anything else in our toolbox for 2024? Well, now there's 4 more things. We have Faricimab, We have high-dose Aflibercept at 8 milligrams, the port delivery system only available so far with ranibizumab, and biosimilars that so far are only available to the reference product ranibizumab. The biosimilars to a reference Aflibercept are FDA approved but not yet available. These will reduce the cost, but we have less safety data than these older agents that have been around for more than 15 years. So what's the role of these newer agents on visual acuity, treatment burden, or visit burden in 2024 for diabetic macular edema? Well, in 2022, The Lancet published that there was no evidence of superior visual acuity results comparing Faricimab with Aflibercept at 2 milligrams. And 2 years later, just this year, it was shown in The Lancet that there's no evidence of superior visual acuity outcomes comparing Aflibercept high dose with Aflibercept 2 milligrams. But what about durability? Well, all three can have strong durability, but there's actually no definitive evidence of stronger durability with Faricimab or Aflibercept 8 milligrams compared with Aflibercept 2 milligrams. But wait a minute. Isn't it true that 70% of Faricimab participants can be extended beyond 8 weeks with visual acuities that are not worse compared with Aflibercept 2 milligrams? Is that stronger durability? And didn't we hear that about 90% of Aflibercept 8 milligram Q12 week or Q16 week participants maintain that dosing interval up to week 48 with not worse visual acuity outcomes compared with Aflibercept 2 milligrams? Isn't that stronger durability? Well, Aflibercept 2 milligrams was never given the opportunity in these trials to extend beyond 8 weeks. But now we have that evidence with Faricimab and with high-dose Aflibercept. Do we have any evidence with Aflibercept 2 milligrams? Yes, we do. Protocol T showed us excellent durability of Aflibercept 2 milligrams in year 2. These are data from Protocol T, and they show you how many injections were given, who got 1, who got 2, who got 10, who got 12. And 21% in year 2 had 1 or 0 injections with Aflibercept 2 milligrams. And 36% had 3 or fewer injections in year 2 with Aflibercept 2 milligrams. These were given the chance to withhold in a PRN regimen. And many eyes then had less than 6 injections without sacrificing the visual acuity gains that were seen in year 1. What about the visit burden? Well, we can't know, because in the Faricimab and high-dose Eylea studies, the participants were seen every 4 weeks. So they didn't study visit burden. We don't know if there's less visit burden. What about all these exploratory analyses, these post hoc analyses on anatomy? Well, that's just what they are, post hoc or exploratory. We know that there's greater reduction of hard exudates from these studies, greater volume reduction. But these anatomic outcomes just generate hypotheses. Just a reminder, they do not translate into better visual acuity outcomes. What about switching to just one of these newer agents? Well, Dr. Ferris told us in studies of effects of switching anti-VEGF after a poor initial response, he asked, can we just assume that there's no further improvement if there's no switching? And he looked at eyes meeting criteria for switching, but maintained on their original agent, and he showed there was actually sometimes improvements when you had an inadequate response later on in visual acuity or retinal thickness. So he said a control group maintained on the original agent should be included in studies of switching. Clinical trials haven't done this yet. So in 2024, there's no evidence of superior visual acuity outcomes. Biosimilars will reduce our costs, but we have less safety information. There's no definitive evidence that switching to newer agents provide long-term benefits. That would require trials of switching to the newer agent. And finally, there's no evidence of stronger durability, because at this time, there's no definitive evidence of a decreased injection or visit burden. Thank you for letting me share that.
Thank you, Neil. Next, we'll learn what's in the pipeline for diabetic retinopathy, presented by Dr. David Boyer.
Lisa, thank you very much, and the organizers for allowing me to do this. These are my financial disclosures. Why do we need additional treatments? We just heard a great lecture by Dr. Bressler talking about what we have currently. But if you look at Protocol I, you can see that there are 3 basic swim lanes. You have patients that do extremely well with anti-VEGF therapy, getting close to 14 letters. You have some that have lesser response, gaining about 8 letters, but you have a group that does not dry and has a very poor response. What are the shots on goal? You're going to see a lot of trials that I'm going to show you that are currently going on. Some are for the treatment of diabetic macular edema. Some are trying to improve diabetic retinopathy severity scores. Others are reducing the vision-threatening complications. Others trying to improve macular ischemia and better compliance by some of the longer-acting drugs that was just discussed. Medical management is still the first line, and sometimes we forget that. Control of blood pressure, control of sugar, smoking cessation decreases the complication. 1% decrease. If the patient goes from an A1C of 10 to 9, they reduce their complication rate by 35%. There are a number of drugs in the pipeline right now. We'll talk about UBX 1325, multiple TKIs, OP302, a Kodiak drug, and biosimilars and gene therapy. TKIs block all the VEGF receptors, VEGFR1, VEGFR2, and VEGFR3, and they are intracellular. They also do PLGF. There are a number of companies in this space. Some are treating intravitreally, some are treating suprachoroidally, and some are actually going oral. The shot on goal for this is the treatment extension, to give one injection, hopefully every 6 months, to maintain the present level of edema. You heard a great lecture, if you were present, by Dr. Wyckoff today that talked about a new drug, Restort, which is a norimimetic and a Wnt agonist. And this is a little complicated system, but basically there's clustering that allows the drug to be functional. It's been around for a long time, but until recently was not able to be available. The results were very wonderful. The first 12 weeks, there was 11.2 letter improvement with this drug. It's intravitreal injection, a reduction in excess OCT thickness by 80%, absolute reduction of about 143 microns of fluid. And we're waiting for additional treatments or additional information regarding this. Topical treatments have been tried. Some have failed already. We'll discuss OCS-01, Exenate EXN-407, and KHK, which is a TKI topically administered after loading doses. Let's talk about the OCS-01. This is a topical dexamethasone drop. The mean change was 7.2 letter improvement against vehicle. The secondary endpoints were percentage of patients gaining 3 lines of vision, which was 25% with the topical application versus the 10% in the vehicle. And the mean change in CST similarly went down about 63 microns. If you look at the best corrected vision in these patients, in either naive or previously treated, you can see it favored the patients receiving the topical drop. And here is the plot of the visions over a period of time. And you can see 7.6 letters versus 3.7 with the topical application. Gene therapy is very sexy right now. We have several companies that are doing it. Regenexx Bio, suprachoroidal, and also subretinal. It's a ranibizumab-like drug. 4DMT is an Aflibercept-like protein that has control over VEGF-A and B and VEGF-C. So it really blocks all the receptors. The improvement in DRSS with the ABX RGX-314 was pretty substantial, that about 70% of patients gained something. But if you compare it to what we've known from anti-VEGF therapy, it was approximately equal in the diabetic retinopathy severity. There are a lot of new modes of action. There's a bispecific anti-VEGF and integrin, AG73305, AXT107 destabilizes AVB3 and clusters Tie2. You have the inhibition of nuclear factor KB, fusion protein for VEGFR, and others. Here, AG73305 is a bispecific. It has an anti-VEGF, very similar to Aflibercept, but also has an integrin. And the integrins take a while to work, but they last for a long time. And here, this was a drug that was made to try to prolong the need for treatment. So one treatment lasted much longer than we would see with just an anti-VEGF. UBX1325 treats senescent cells. What are senescent cells? They're cells that are no longer reproducing. They actually have ICAMs and other inflammatory factors, and if you can rid the area, the retina of these, you reduce the inflammation. And in the BEHOLD study with UBX1325, after one injection, 6.2 letter improvement at 48 weeks. And about 50% of the patients after receiving one injection were rescue-free interval. APX3330 is a REF inhibitor. It's a oral medication and is being looked at to go for reducing visual loss. Gene therapy, there's two major companies. We have RGX314, the Altitude study. This is a AAV8 that makes an antibody very similar to ranibizumab, and there are 4 ascending doses. You can see here patients treated improved their diabetic retinopathy very, very, very quickly and very well. Even when you compare it to an Aflibercept injection or ranibizumab injection monthly, you can see that they were right in the same ballpark in reducing the DRSS. Spectra 4D150 phase 2 trial. And again, this is a blocker of VEGF-A, B, C, and PLEGF. The primary endpoints analyzed number of Aflibercept injections in the study eye. Endothelium has been linked to many systemic diseases. ET1 is being looked at as a potential reduction in retinal vascular ischemia and will hopefully go forward. OPT is a VEGF-C and VEGF-D inhibitor. We've already spoken about the advantage. This is a separate injection given with any either ranibizumab or Aflibercept. And it did show a significant improvement compared to the single agent. I want to thank you very much. I hope some of these come to fruition and help our patients. Thank you very much.
Thank you, David. That was fantastic. We'll conclude this session with our panel discussion, moderated by Dr. Raj Maturi.
Thank you, Lisa. Good afternoon, everybody. We have an esteemed panel here that I'd love to introduce Julia Haller, Justin Gottlieb, Jack Wells, and Rukhsana Mirza. We'll go through some diabetic cases. Some of these are very normal, but I'd love to get this esteemed panel's ideas on them. That's the first case. That's the title slide's actually the fellow eye of this patient who came. And this is how this 45-year-old type 1 with poor follow-up, visual acuity of about 20/70 in this eye looks. The fellow eye's hand motions, and it'll go through what it needs to go through, and we'll probably end up with a very good 2400 at the end of the day. What would you do for this eye, Julia? First, what do you see, and how do you think you'd approach this?
Well, first of all, when I look at these two eyes, I'm struck by how our healthcare system has failed. In this particular case, with severe ischemia and neovascularization. And I want to think, are there patient navigators? What can we do to change the course? Because this patient's other eye is down the drain, and this eye is headed that way. And when you look at the red flags, young, type 1 diabetic, poor follow-up, huge red flag. Vision in this eye is already bad, and then with the other eye so severely damaged. So I think every possible, he's probably hemoglobin A1C is probably 11, probably has sleep apnea, probably has depression. I mean, there are just so many things going on. And this is a patient that takes a lot of chair time, and we have to do our very best. In these cases, thinking about anti-VEGFs and laser, I feel like PRP is money in the bank. And when somebody is not going to be coming back, probably, you can at least get a baseline start on treating them. I would combine it with an anti-VEGF, and I think I'd be interested to hear what my fellow panelists say. I think this is a situation where is it worth thinking about an early vitrectomy, a preemptive vitrectomy, with
Sure.
all due humility?
Sure.
Yeah.
Susan Bressler presented Protocol S data a few years ago about loss to follow-up, and Adrienne Scott just now presented data with significant loss to follow-up that happens in every one of our clinics. Jack, what would you do?
Well, the first thing I'd want to know is the vision's 20/70, and the fovea doesn't look that bad. So I'd want to know if they have DME or not. You didn't.
They have some DME.
Because that might explain why their vision's 20/70. So if they have coexisting DME this eye, I would definitely start with injections. I'd try to get the family involved and impress upon the family and the patient, the importance of follow-up. I usually give people one strike if they don't show up. If they ever come back, they get laser. I would definitely, if you didn't say anything about the other eye, the title slide, but I would definitely laser that eye. And this eye, I'm very sensitive to the visual field loss in a 45-year-old man. I don't know his circumstances, whether he's working or not, but
Sure.
I would favor anti-VEGF therapy if he would follow up.
The two things that we have found out in 2024 is some of the DRCR data looking at baseline DR severity and overall non-perfusion, and there is significantly more non-perfusion in the PDR eyes, as we could see here. And disease worsens faster when there's increased non-perfusion. Second thing is, this is from Justice Erler's slides, where increased leakage is also associated with increased worsening, and we have that issue with this subject, or with this patient. Okay, let's go to the next slide. Next case. Justin, this is a 70-year-old Hispanic female, 10 years of known diabetes, 20/50 in this right eye. Edema, as you see there. What would you like to see? What would you like to do?
I'm relying on the photograph. It's a little bit hard to say if there is a presence of PDR. I'm going to assume in this case that there is no PDR without a fluorescein.
Get closer to the mic.
Oh, sorry. So I'm going to assume there's no PDR. Sometimes a fluorescein on the initial visit may be helpful. And in fact, there looks like there may be a small tuft of neovascularization just below the inferior arcade.
Does that change your treatment pattern?
No. I mean, I think because of the presence of the diabetic macular edema, this is a patient who I think it's a pretty easy decision just to begin with anti-VEGF injections for the treatment of DME, which will control the PDR. And this is a patient who may do very well without needing a laser in the future.
Sure. What anti-VEGF, do you have a choice of in this matter?
We have a lot of choices, and we just kind of heard a little.
Neil just spoke to us about all of them.
That's correct. My practice is almost always beginning with bevacizumab.
All right.
I'd say 99% of times. I still do look back at Protocol T, and if there's severe edema with greater than worse, I don't do a refraction, but if the visual acuity is poor already, then I will consider starting with Aflibercept. I honestly don't know the role of the longer acting.
Sure. Jack, do you want to tell us about Protocol AC and possibly how starting with Aflibercept or bevacizumab would work here, or any other agent?
Well, in Protocol AC, they took eyes with 20/50 or worse vision and randomized them to Aflibercept or bevacizumab. And I think, to me, the most impressive thing about that result was that 50% of the eyes in the bevacizumab group switched by year 1 and another 20% by year 2. So we saw in Protocol T that, bevacizumab treated eyes with baseline vision worse than 20/50 could do well. I think about 40% of the eyes in Protocol T did pretty well, and that was the genesis for doing that study. I tend, to not start with bevacizumab when the vision's 20/50 or worse. I tend to start with Aflibercept.
All right. Rook, do you have any thoughts on this one?
So as far as starting, obviously nowadays you also have to check to see if step therapy is warranted, and so that's generally the first thing that I ask my staff: are there some requirements here?
Sure.
And then Yeah, so the other thing I would note here is that the hyaloid is attached, and sometimes that's also a feature of how they may respond in the long term. But the other thing I really do with these patients is sit down and say, this is a commitment, and one injection is really is meaningless, right? So one injection is not going to do much. I spend a lot of chair time, as Julia was mentioning, saying like, blood sugar, blood pressure, cholesterol, make sure they're connected with their medical doctors, and saying that like this is a commitment, and this is, I usually start with just one eye and have them come back for the second.
All right. So Neil presented data from the various studies showing no differences. We looked at the Vestrum database data just for naive patients and what happens after 5 injections of that same drug in diabetic macular edema, and all of them improve in vision, and all of them improve about the same amount in clinical practice. And if you look at the slide on the right, that's one important thing I take home. When I see a patient with very poor baseline vision with DME, let's say 2400 or so, that there's a significant chance they'll improve 4 or 5 lines. Or if they're starting at 20/40, at most on average, they'll improve about 1 line. So knowing that difference and how much improvement is so based on baseline vision is one of the things I take home to them. And the other thing I can see, at least on averages over at least a few hundred patients to many thousands of patients, is that visual acuity is about the same in terms of improvement for each group. This is the fellow eye of that same patient, Rook, 20/20 vision in this eye. Would you treat this eye or would you observe this eye? You can see edema in the FA on the right, and a little bit of exudate. The foveal center itself looks pretty flat, and she's completely asymptomatic.
Yeah, so this eye, there's no center involving DME, so I would observe this eye at present.
Michael Ip presented some data yesterday showing that the AAO's guidelines have shifted a little bit towards anti-VEGF treatment for severe NPDR. Would you treat her for the severe NPDR and also get the benefit of the mild edema at the adjacent area, Jack?
I personally don't treat severe NPDR, and I probably, would not in this case, and I wouldn't even think about doing a focal laser because it really doesn't meet that criteria of clinically significant diabetic macular edema either. So.
I'm glad that Jack mentioned about focal laser. I don't, looking at where the edema is present in this patient, I also would not treat. But I think that the patients who have non-macular center involved edema, if they're threatening, we've used that treatment for our whole careers. And it works very well. And it may be, it may prevent them from needing injections in the future. And I think that that's something that we need to remember is available.
Particularly if you've got some hard exudate
Yes.
starting to make its way into the fovea where we know it'll be toxic.
And you can even look at the FA here, and it looks like that's pretty focal looking leakage. Now, assuming that there was actually edema closer, that may be a case that's well and quite easily treated. Now, more in my hands now, I never treat a diffuse edema patient with laser. It was, somewhat frustrating. I end up with big scars years later. But the ones you could put a couple of spots on top of microaneurysms with a real gentle grid, those patients did very, very well.
So we treat severe NPDR with anti-VEGF, especially if there's some edema involved and the edema decreased, and that's what you have. But the key here is to remember protocol V data does apply. Observation versus initial anti-VEGF with Aflibercept versus focal laser had the same result. The key here being the observation group was not just observation, but it was observation until there was vision loss. And treatment was always initiated at the time of vision loss below 20/25 ETDR is corrected. Let's go to the next slide. Julia. This is a 59-year-old gentleman who's had very good PRP in both eyes. He's on Eliquis, and he keeps bleeding in each eye. Every 6 months or so, he bleeds in one eye. Is there anything else you'd like to see?
Yes, I'd like to see his OCT, look at the status of his vitreous, and try to understand what's going on here more. To me, this looks like he's got quite good PRP. And we see, so, and especially on the color photos, it looks like the PRP has worked, and you'll see there's no macular edema, but more to the point of the PRP, the new blood vessel growth has regressed, but now we've got, so it's not a biologic problem, it looks like it's converted to an anatomic problem, and we are getting these fibrous pegs with traction from the evolving PVD. And what I worry about from the previous photo is the way it's pulling on this crescent temporally. And I worry not only about the problems from not being able to see through blood, but also the traction evolving into distortion of the macula. So here again, I'm thinking of the late and dearly missed Paul Ternambi used to quote his dad, who was a general surgeon, who said, "There's no problem that can't be made worse by an operation." So, I think we have to be cognizant of that, but this might be a case where a patient with excellent vision could hold on to vision if you thought of a preemptive earlier vitrectomy. Just a thought, depending on how much blood.
Yes, and that's exactly what we did. We observed one eye, and we treated the other eye with vitrectomy with a good result.
And how? And when they have the recurrent hemorrhages, I mean, is there just a role with treating them with a anti-VEGF, and just hoping and watching it clear, giving it some time?
I mean, that's a really good question. I'm not sure that's actually ever been studied. What would you do, Justin? 5 times a year there's a bleed. He's on Eliquis, he can get off it.
And can you tell the difference between active and non-active residual neovascularization?
No, I mean,
the fundus photo is actually more useful in those cases than the fluorescein angiogram. The fluorescein will always give you an area of leakage in the area of fibrosis that happens after complete inactivation. So the fundus photo and clinical exam, where you can actually see the traction temporally, gives me the best clue.
Right, but I do have a few patients who, health reasons or do not want to have surgery, who I will treat once, twice, 3 times a year. And sometimes we know that if you treat them once a quarter, they won't bleed again. I do think that fluorescein is helpful and that it shows you there is some NV there. And I suspect that you're absolutely right that there's some traction and they break.
Yep.
But I think that I often will, and sometimes while you're getting the injections, you'll see the vitreous detach, and then you're really happy.
You induce a PVD.
Right, exactly.
Well,
Yes,
and
Jack.
do you modify the drug you use? Are you thinking of antifibrotics or no?
No,
Yeah.
I don't.
Jack?
Yeah, so, no, I was just going to say, to me, it would depend on how disabling these hemorrhages were to him, and if he really felt like he needed to do something about it. I would probably use injections first. I would be sensitive to the status of his lens. If he's phakic, I'd be hesitant to do surgery quickly because he's going to get a cataract at age 59. So I would tend to go with injections because I think you're probably not going to have to do very many to keep him fairly quiet.
Sounds good.
I would also do
Yes, Julia.
some OCT scans temporally and track that and see if it looks like he's developing a tractional detachment out there.
Okay. Next case. This is Rook's case, a 52-year-old male with sudden vision loss, known diabetes for only 3 years with a long history of hypertension. He's a bunch on diabetic medications and SGLT2 inhibitors. And he presents with this as a baseline. Rook, actually, yeah, go ahead. What did you do for this patient?
Well, so this was the better eye of the patient. So this patient, again, a lot of chair time, and we discussed control of his sugars, blood pressure, cholesterol. He had recently been put on some of these medications. So again, because this is in the context of the other eye, he received, we discussed injections for his DME as well as laser when able for the other eye, but this eye received injections.
Sure. And it improved nicely after a few injections. This is the fellow eye, counting fingers at presentation, dense hemorrhage on the B scan. What
Right.
would you do, Jack?
I would treat him with an injection first, but I tend to go to surgery sooner rather than later in eyes like this. I mean, Protocol A/B showed you get faster vision rehabilitation with surgery. I know ultimately the treatments give the same long-term outcome, but I also feel like the good thing about vitrectomy in an eye like this is that you dramatically reduce the risk of him having rebleeding in the future.
Are you combining that with cataract surgery?
I don't do it in combination, no.
And Rukhsana, it looks like there's a tuft on that. I think that's a PE ultrasound. Was that NV or was
Yeah.
that was not a tear?
No, that was not a tear, but we were worried about that. So I always do the ultrasound to see what type of traction or what is happening in the back. Also, I get concerned doing an injection, but I consulted with some of my colleagues who are surgical retina as well, and I did proceed with an injection.
So were you worried because of crunch? You worrying about pulling something
Well, when
up?
there is traction like that, and there is that, I'm worried about that. Just spontaneously, I've had some patients with posterior kind of tears, holes, breaks, and then crunch. But there was only one focal attachment.
But with if that is NV, presumably that's maybe a perfect case to do a surgery on. Remove the traction, you can treat that at the time, get a good PRP in.
Absolutely. But
My standard is to do an injection and then schedule them for vitrectomy the same day. So he'll come in a few weeks to get the vitrectomy and it's all done. But he didn't do that. He came back a week later at 20/70.
right. Well, we planned all of this. He had received all the information about surgery, but this was a kind of it's a lot for a 52-year-old who's otherwise healthy to come in now suddenly with all these problems. And when you see them like this, you know that there's more than just this going on, right?
And I think that was the key point here. The patient improved nicely with anti-VEGF injections and PRP, but she did one other thing.
Yes, I had him have a cardiovascular workup, and it came back with a very high calcium score. So he's going to, undergo more workup for that.
And that's actually one of the important things we can do. Patients who are non-compliant will often come to us when the visual is down, and this is the time to see them and tell them the things that they need to keep them alive. This is something that's in the news lately. 68-year-old diabetic male, sudden vision loss of 3 weeks, 10 years of controlled diabetes, history of the usual vasculopathic risk factors, and he presents with sudden vision loss in his right eye. And you can see a Goldman visual field, you can see a supratemporal defect, it's pretty dense. You can see a little bit of disc edema on the fluorescein angiogram. What do you think is going on here, Jack?
Well, I know that it's been in the news that there's an association of AION in people on these medications. So I haven't personally seen a case of this in my practice, but I assume that's what's going on.
Yeah, this is from actually 2 weeks ago in my practice. So,
Well, I ran into Joe Rizzo on the way over here, and who is the senior author on this report, and asked him if he's got any new tips for the rest of us. And they've just put together a list of recommendations for the internists at the Mass General Brigham. And as I think most of us have been talking about with our patients, if you need to be on it, the overwhelming advantages of the drugs probably outweigh the small increased risk. It was actually a 4-time increased risk, but only to about 8.9% in these diabetic patients. But he recommends that if the patient already has severe visual loss, so for example, they've got severe glaucomatous cupping and visual field loss, then you may want to think about a different way to approach their medical problems.
thank you. Thank you all. The key is to make sure they don't have nocturnal hypotension from their blood pressure medications, and always make sure that your patients are on some SGLT2I inhibitors or GLP-1 agonists, because both of them help their general health, and we can tell them that. Thank you. Thank you all for your time.
Thank you.